we'll just start with meeting logistics here. The call is being recorded. We will send that out or post that on the NCC YouTube in the next coming week or so. Everybody is muted upon joining the call. We will be using the chat feature when we have questions and to ask questions of our presenters today. So please, we'll have a couple check-ins there, but please don't be shy. Put the things in chat. I'll help moderate and I can ping the questions to the right presenters. And all of this will be posted in time to the ESRD NCC website. So today on the call, we have dialysis facility and transplant professionals, our ESRD network staff. We have our CMS leadership, and of course, patients and families. So the objectives for today's call for this Depression Learning and Action Network are really to identify barriers and solutions to effective depression screening, define some best practices within dialysis facilities. We'll be hearing real-world cases on that. And then also, talking about how to establish systems to sustain these processes for screening and follow-up. So today, really to spread the best practices you'll be hearing, please be active in the chat feature. That's a great way to get some conversations going, ask your questions, identify, start thinking about how you might use this information at your own facility or in your own care journey. And, at the end, we'll talk about taking this to action. So again, start thinking about, if there's one idea that you could take today to your facility and then commit to sharing what you learned here, what you heard here with colleagues in your professional workplace. So again, just try to set some questions to run on as we get started here, things to keep in mind. So as you listen to our presentations today, we have 3 ESRD networks, 3 professionals. Are there any aha concepts that you might hear that you could introduce to your team or to leadership? What might be the benefits to using the change package? And then in what ways can the organization, adapt and adopt what we're doing on today's call to your own facility? So we're just going to try out that chat feature, get everybody engaged here with the first question, and that is, have you previously used the ESRD NCC change packages? So I'm going to pull up chat here and let's see if we get some responses. Great. And when you do click to your chat feature, please do the to everyone so we can all see the same. If not, it just comes to panelists. So I have a couple of yeses. At the conclusion of our presenters, I'll take a deeper dive into the change packages and give people the link to those. Okay, some no's, some yeses. Great. Love seeing people chime in there and get in the chat feature. We'll be using that throughout the presentation. So here's a brief overview to some of the change packages that the NCC has posted. We actually just updated and published these. So again, I'll give you the link at the conclusion. But we did post, I think just yesterday, the new depression change package. There's a screenshot of it just as an introduction there. And I'm going to pass it. We have a lot to get through today. I'm going to pass this right over to Debbie Ohm for an introduction for her speakers from networks 10 and 12. Debbie?
Thank you so much. My name is Debbie Ohm, and I am one of the quality improvement advisors for both networks 10 and 12. If you want to go to the next slide, actually the next one after that. So I wanted to give you all just a little bit of background about both of these networks. So Network 10 covers the state of Illinois. It has about 346 dialysis facilities, 9 transplant centers, and almost 32,000 ESRD and transplant patients. Network 12, as you can see there, covers the states of Missouri, Kansas, Iowa, and Nebraska. We have about 318 facilities with 12 transplant centers and almost 29,000 patients. Next slide. So in option year 1, which is what we just finished, we used available data to identify facilities that were both low performing and high performing. These calls helped us identify what was happening at the facility level. We also used our community partners, community coalitions, cohort facilities, and patient groups to learn more about the needs and resources in the community. Through the end of option year 1, data in network 10 we had discussed that many of the Fresenius facilities were in the top 10% of this measure. So we have invited some of them to serve on our Behavioral Health Community Coalition in option year 2 to mentor and help the lower performing cohort facilities through the PDSA cycles. So with that, let's see, I want to move on real quick to some of the best practices that we had identified, and then I will move on to our first speaker. So some of the best practices that came from Network 10 in option year 1, facilities were able to utilize the Q-Source bulletin board kits for expressing gratitude and reducing mental health stigma. This helped create an open door for staff and patients to talk more freely about mental health, and the feedback that we received was that it was a great conversation starter. Another facility was able to do a mental health lobby day where they had resources from local mental health centers, informational handouts about depression and mental health, and a social worker on hand that was available to talk to them and answer questions that they had. This was really the first thing that they were able to do kind of post COVID-19 lockdown. So the event went over really well. So we were happy to hear about that. The FMC regional social worker in the Illinois area, we had recently learned that she has become certified as an instructor for mental health first aid and is now certifying all facility administrators in the Chicago area for this. So this will help them identify, understand, and respond to a mental health or substance use crisis. And the course is offered throughout the United States. So if you want any more information on that, it can be found at mentalhealthfirstaid.org. Next slide. So speaking of FMC and some of the great things that they are doing, I wanted to introduce Carri Massau-Ables, and Carri is a licensed clinical social worker and represents the Social Work Advisory Board at Fresenius Medical Care. So Carri, if you want to get on and talk about some of your best practices that you all are doing and some of the work of the Social Work Advisory Board, that'd be great.
Thank you, Debbie. Thank you all for having me on today. With the Social Work Advisory Board, we're a nationwide resource, and we're there to share practices among all of our Fresenius social workers. One of the things that I do with the Social Work Advisory Board is I am on the Navigator, and it is a newsletter that comes out quarterly. And we talk a lot about different topics relevant to social workers. We talk about policy. We talk about transplant best practices, anything that comes up within our realm of using the technology that we have. Huddling up, what can we share with others? And really recently within our Navigator, we also talked about, I know that Debbie, you had talked about depression. We had articles about person-centered counseling, using empathy, being present with the patient. Those are those articles that we pull out of the Navigator. And within Fresenius, we have the depression screeners, which most of you are probably very familiar with. We have the PHQ-2, the PHQ-9, the wellness assessment, and the GAD-7 for anxiety. Did you have any questions specifically, Debbie, for me on that?
I know you talked about some of the different best practices that are shared through that, as well as some of the things that you have done in your clinics. I know that in addition to the mental health first aid, there was some challenges with some Spanish speaking. We had talked about that a little bit, finding resources and having staff that are bilingual to help out with that.
And in the absence of any staff that may or may not be present, we also have the language line that we can use to assist our patients in any kind of emotional needs that they might have. Also referral process to getting patients to use the mental health resources that we have. I think that's one of the biggest challenges I know that we had talked about as well, is getting patients to use the resources that we put out there. Sometimes it can be a lack of transportation. It can be a lack of knowledge about the resource. And sometimes it's the stigma of mental health as well. And I think that's one great thing about the mental health first aid that's going to be coming down the pike, is that that's going to help us empower our patients to want to be able to get the help that they can. In the clinics, as a social worker within the clinic, we always meet with our patients. We provide what's called focused interventions that helps patients through their depression and anxiety, which may or may not be related to the dialysis they have. Often these patients, as you guys know, have a lot of other social and economic and physical health problems too. So helping them navigate all of those pieces together throughout their dialysis time here and being a support system to them.
That's great. And one of the huge barriers that we've dealt with over the last couple years of this project is patients maybe not necessarily being willing to seek treatment. So is there anything that you all do to work with or help motivate those patients that maybe are hesitant to seek treatment? How might you work with them to kind of motivate them to seek some sort of mental health treatment?
Well, I think a part of it is too, with our staff here, we've been very supportive of our patients and letting them know that they're not alone and they can talk to them just as they talk to us. Coming to dialysis 3 times a week, the patients often become extremely comfortable with us and they feel like they can tell us anything. And sometimes that new person going to them and saying, I'm struggling with this, I'm struggling with that, might be out of character for them. So really focusing on the piece that it's a safe space here, it's a safe space there. If you want me to, I will help you with this and follow back up with me about how it goes afterwards, but just reassuring them that they're not alone and kind of normalizing that as well, to let them know that we're all in this together as far as helping you guys to support you through whatever you're struggling with.
Okay. I know one of the other things that you mentioned that you all have done with your newsletter is talk about health equity issues, which I know that's a big thing with CMS right now, is really trying to look at those inequities and seeing how we can best help our patients. I think you had mentioned you had done, or there was an article about food insecurity, because I know, we do hear a lot about that, because food insecurity and, people maybe not being able to afford housing and how that can affect depression. Is there anything specific you wanted to address on that?
Absolutely. The case that I highlighted was out of Ohio, and the clinic had actually partnered with a local food bank. It's interesting because there are resources out there, and sometimes just partnering with these area agencies to come together to assist the patients and tapping into resources that you wouldn't have known otherwise. In our area, we have a mobile market that goes to different sites. It's not at the same site every single time. So patients are able to go and visit the different sites with their identification and get some support. I've even talked to the local food banks as well, and they know that times have been so difficult that they're able to look at people and say, okay, if you're in a crisis situation and you're not yet a resident of Indiana yet, we can still assist you. But the one in Ohio was really neat. I believe they partnered with the Cleveland Clinic, and they were able to actually bring the food to the clinic for the patients. It was not mandatory that the patients had to take this. It was by their own choice if they wanted to. And some patients were a little bit reluctant at first to take it, but they actually saw a lot of progress with the patient's labs, which I thought was pretty phenomenal. Phosphorus is dropped. And it not only increased adherence with their diet, but it also increased adherence with their binders and other medications they were taking. So not only did it support the food insecurity piece, but it also supported the patient's adherence to their diet and also their medication regimen.
Yeah, I think that's what we've heard as well. And I know that there are some dietitians that are working directly with some of those food banks that, are talking to them about kind of setting aside some of those more renal friendly foods, since, a lot of the foods are canned and things like that go into a food bank. So I think even getting the whole team involved in that and maybe trying to decrease that barrier might help patients with their stress and depression levels. So,
and even just little helpful hints, like if they get canned vegetables, then strain them, take some of the water out of them, rinsing things off if you have to, and then just shaking it and making sure that you have the moisture out of the vegetables. And even cooking at home, because cooking at home for one is difficult. And a lot of our patients live alone. Fast food is convenient. They get out of dialysis, they're very tired, they don't want to do anything, and it's just easy to go through a drive-through. And this allowed them to get the tools to be able to create those meals at home. And it was empowering for them as well. Not only were they getting healthy, but they found that they could do this task that wound up being simpler than they realized.
Mm-hmm. Yeah, I think all of those can contribute to the overall sense of well-being for patients. I know you had also mentioned patient-centered counseling was something that you all kind of focused on. Is there something specific about that you all are being trained on, or kind of social workers in general being able to find the time to do that more with patients?
It is hard because sometimes as social workers, we're so inundated in our clinics with all sorts of issues. We've got transportation, we've got transplant, and there's a whole flurry of stuff that's often going around in the clinics when we're there. And sometimes it's hard for us to actually just be with the patient and be present. And I think one of the things that we really have to focus on is starting where they're at, because, and you spoke about, health insecurity and just general equity. I can think of patients who they can't see past today. They're just trying to make it from day to day, and starting with them in where they're at. And if they can't make a long-term plan, then that's okay. Just start where they are, and make sure that they have what they need to get through the day. And then whatever the future holds, we can continue to work with them. And it's not always easy. There are some patients who you can get to plan for longer term, and we can get them to come to treatment. I know adherence is a pretty big issue too as well, but just working with them and really starting where they are and focusing on any kind of barriers. That's also a big one too with us, with our focused interventions, is getting to the root cause. Is it transportation? Is it, you can't come to treatment, or you can't get to other appointments because of gas money, or whatever your circumstance might be, but just really working with them to start where they are and seeing what the barrier is.
Yep. I think that's very important. One of the couple main things that we're looking at with this quality improvement activity is accurate screenings, and then follow-up mental health treatment for those that are screening positive for depression. So does FMC have a process in place to remind social workers, number one, to do the screenings, or if a screening is positive, is there a way that it alerts you to check up with those particular patients after you've provided a referral?
After we do any of the screenings within our assessments, if somebody triggers for depression on the PHQ-2, the assessment automatically takes us to the PHQ-9, which is really nice. And then from there, we do get a reminder within our charting system that a follow-up is required. Sometimes I have to look in there myself just to go through my alerts and make sure I'm not missing anything. And again, just really sticking with those patients, following up with them. And even if a physician is recommending a psychiatrist, talking with the physician after we get our scores back from the depression screening. Especially if the score is on the PHQ-9 is 10 or higher, then we can work with the physician and the interdisciplinary team to make a plan for this patient. Will they be able to see a psychiatrist for psychopharmacology? Will they be able to connect with a counselor? Or is there something off on their labs? Working with the nurse and the dietitian just to see if there's something else not physically related to their situation, but also mentally, what exactly is going on?
Okay, great. Well, I appreciate that. I think there might be a question. Sarah Eve, did you want to?
Sure, just going to hop in. We got a couple of questions, Carrie. One about that newsletter, if it was specific to patients and families or if it was for other clinicians.
The newsletter is strictly for social workers within the Fresenius social work realm.
Okay, great. And then two folks, different topics here. One, as suicide risks and numbers increase, are there any toolboxes or resources for dealing with suicide? And then also resources for folks who are perhaps blind or visually impaired and unable to complete their ADLs who are depressive. So two kind of, unique categories there, if you could speak on those.
I will start with the second question from Taylor about the blind and unable to complete their ADLs. First thing I would start with are what resources for the blind are available. I know within the Chicago area, there's Chicago Lighthouse for the Blind. They've been a wonderful resources for our visually impaired patients, starting with the blind resources and finding out what they have available. And then from there, finding out also if they have someone who has a social work or mental health degree within there to address the blind symptoms, because it's very hard, and we have a lot of patients who are visually impaired here, and it's devastating, especially those who were independent for years, who have lost their sight, and they don't know what to do at this point, and obviously that would make them very depressed. So I would say starting with the blind resources within your area. And then for the suicide risk, I know that we have posted the 988 number in all of our clinic areas. And one of the first questions that we do ask on the PHQ-9 is assessing for suicide, asking if they have intent, asking if they have a plan, and asking if they felt that they were better off dead or if they weren't here any longer. And those are two very difficult questions to ask. And I know as social workers, it's kind of scary sometimes to ask that question, but with the numbers going up as they are, it needs to be asked.
Great, thank you for that. Thank you for that, Carrie. Mm-hmm. Back to you, Debbie.
All right. Thank you, Carrie. We will move on to the next. Move on to Network 12 best practices that we had learned. One of the things that one of our smaller dialysis organizations, they put on a yearly patient engagement day. So the picture you see there is their clinic staff. The theme was the 80s. So our network staff was able to join them and have a table of resources for their 2-day event. So they had not only community mental health information, but also information about home dialysis, transplant, and other community resources that address health equity and social determinants of health. So it's kind of like one of those lobby days, but on steroids and at a different location that's, central to both of their clinics. So that is a great thing that they do. So they bring patients and families together to connect with those resources. One of the other things that we are working on is with BRL Behavioral Health, which they have several locations in the mid-Missouri area. They're developing a care pathway that will allow dialysis patients from communities close to their locations to receive quick referral to psychiatric services, mental health medications, and longer-term mental health therapy. So we're excited to see those outcomes for option year 2. One of the other best practices that we learned about is a facility that is using master's level social work students in their clinic. So we thought this was a very inventive, kind of innovative way. And the facility has great things to say about it. So I will, if you go to the next slide. Nicole Hayes is a licensed clinical social worker and has been the facility administrator at DaVita Swope Dialysis for 4 years. Prior to her current role, she was the regional lead social worker for DaVita. She has a total of 17 years in dialysis, and she will discuss more about the social work students in their clinic, as well as barriers and how they have found a system to kind of help with that. So, Nicole.
I am excited to be on to talk to you guys about what we have experienced with the students. When I was a social worker, I did take a student in my clinic, and we we touched on depression and dialysis patients, of course, and we did all the things that, we've talked about so far on the call, but we didn't think of utilizing the students in the exact way that we did when my current social worker came and talked to me about having students. We are a pretty large clinic in the middle of the city in Kansas City. So we typically have about 110 patients. We have an awesome social worker. She's amazing, and she's always up to date with all the KDQOLs and depression screenings, and the follow-ups are always done. But as many of you know, it's just the time constraints when you have that many patients and the ratio to social work and the other high needs that patients have. There's just not a lot of time to sit down and help them work through depression. And one of the big barriers is that people still don't want to seek any help for it. Just the other day, I had a patient that I know pretty well, and she was like, Nicole, I'm just sad. I'm just kind of sad. And so we talked a little bit longer, and I started trying to go into talking about getting some treatment for being sad, and she immediately shut me down and didn't want to talk anymore. So we still battle that as a barrier. And I feel like time and relationship is the only thing that can kind of break down that barrier. Another barrier that we face in the city is that there are just not enough treatment resources. We have patients that want to see therapy and agree, they want to start, and we might not be able to get them in anywhere for 2 months. Depending on their insurance, it could be even longer. They may be on a wait, or they may have to do, just the walk-in assessment, and then they'll have to make another appointment to go back. And by the time they see a therapist, they feel like it's a waste of time and they aren't even getting any help. So, one of the ways that Jenna and I talked about kind of having more time and being able to build that relationship, Jenna's my social worker, would be to have more kind of bodies to build those relationships with patients and just spending more time with patients, because we see a lot of our patients are, stuck at home and they don't have a lot of family. And so just being able to come into the clinic and talk to people is huge for them. So last year, we did take on 2 MSW students from KU, and we were only going to do 1, but then they asked for a second one, and we decided we could make it work. Since Jenna and I are both social workers, we could work that out. And one of the first things we did was started asking our PCTs to be extremely diligent about checking in with the patients on how they're feeling with stress or being sad. And then any change in mood or any kind of change in behavior, that they make sure they're reporting that to the social workers or the social work students. I was really proud how the team did embrace the social work students really quickly and really felt like they were doing a good job communicating with them. And so we did see some good communication. And then we also wanted to empower the social workers. I've seen some social work students who don't get a lot of experience. They're there and they're following the social worker, that's in the practicum setting, but they're not getting good hands-on experience. And we wanted our social work students to have, the supervision, but also to really feel like they were being able to build the relationships with the patients. So we gave the students, specific patients that we felt were at risk for mental health, for depression, especially ones that we had, already seen signs and symptoms of depression, who had scored high on the depression screenings. And we didn't have them, bust in and start trying to meet with the patients and immediately go into, you're depressed, you need some treatment. we had them start just building relationships. So we would have them just check in with the patient, for 10 minutes. And then once these patients got comfortable talking to them, we would have them check in with the patients for a longer time, to where they started meeting with a patient or two for 30 minutes, each week. And that was really cool, just to see how the patients were excited to just have somebody sit down and focus on them for 30 minutes. And this also would free up some time for Jenna to focus on the ones that maybe were more complicated situations or had something going on that she needed to handle while the social work students were working on meeting with the patients. That specific strategy was drastic. I feel like we had one patient who he had obvious symptoms of depression we'd known for a long time. We had approached him, about seeking treatment before and asked how we could help, and he wasn't interested, and he started missing treatment quite a bit. And we were honestly afraid that he was just going to pass away. And when the social worker started meeting with him, she worked really hard to get to know him. And they built a quick, working relationship, to where he was very excited that he could talk to her when she came in, and he became very open with her. He started attending treatment more, and eventually we were able to get him some mental health treatment that is continuing to work for him. We have really seen a 180 in him, which has been really nice for us and for him, obviously, and his family too. He did start an antidepressant, which also helped. And there's a big, stigma still. A lot of our patients won't try that. We had another success story of a patient that had a schizophrenia diagnosis, very well controlled, but also had a lot of depression and anxiety symptoms. And she was just unable to function. She was unable to make choices to have a safe living arrangement. She had made some choices a while ago that had put her in a situation where her grandma had become her guardian, but grandma had kind of washed her hands of the situation. And so we started meeting with that patient, and the student and Jenna would meet with her just because of the complexity of the situation. And they were able to get her a mental health caseworker who became very engaged with her. And it was really exciting to watch them be invested in her, because sometimes we try to get relationships with mental health caseworkers and it just doesn't work. And so we got that in place, and then we ended up actually going through the public administrator to become the guardian instead of the grandma, because this patient needed some help and she just wasn't getting it. And so that was a whole process that Jenna and I truly believe we would not have been able to concentrate on and work on, and we typically just don't do in the dialysis setting. But with the mental health caseworker kind of buying into all of it, we were able to get a lot done. And that patient, again, is coming to treatment. She's now in a residential care facility and getting her medications that she needs, getting, her fluid removed on a regular basis, having everything that she needs to function. So those are two success stories that we have just been excited about, even though I could talk about more. Go ahead. Sorry.
Thank you so much. No, I was just going to say thank you so much. I appreciate it. I think it's good to hear some of those successes, and although it is a lot of work, that you have had success with that. I know there is some questions that came in. Sarah Eve, if you want to
Sure.
tackle a couple of those, and then we can.
Sure. Thanks for that, Nicole. So I'll go through these. One of them, the first one came from Stephanie Miller. If patients are enrolled in behavioral health services, should there be a coordination between social workers in the community and then at the facility? And how would you suggest folks go about doing that?
We look at it as continuity of care. If it's able to be coordinated, then it does improve. We're right close to Swope Parkway Health Center, so it's pretty easy for us to develop the relationships with those mental health professionals down there. Some of our patients are not going to want us involved. It kind of depends on if the patient's willing to give you the information about where they're seeking treatment. And then if they are, we have most of our patients will say, yeah, you can call them. I'm fine with that. We might go ahead and for protection, have the release of information signed. And then if we have a release of information, the clinicians have been really good about coordinating with us.
Great, thanks for that recommendation there. And then a couple questions about students. So are MSW students able to see patients in the treatment setting? And then also, are they able to administer the KDQOL?
They are able to do both.
Great.
That's one of the things that Jenna, monitors the responses to the KDQOL and how they follow up, but they are able to do both.
Okay, and there were a couple comments in there about telehealth services. I'll let the audience read through those. Again, some great feedback there. Appreciate the comments in the chat. Debbie, Nicole, if you have any concluding thoughts?
I don't. I just wanted to thank Nicole and Carri, and thanks for your time and expertise. And if anybody has questions, feel free to reach out to me, and then I can maybe get you in touch with one of them if you have specific questions.
Great, thank you. We are going to move on to our next presenters from Network 11. I'm just going to take 1 second here to unmute Renee. Renee, you should be able to unmute yourself if you would like to introduce Network 11 and your speaker.
Okay, great. Well, this is Renee, the Patient Services Director from Network 11. We cover 5 states, Minnesota, Michigan, North and South Dakota, and Wisconsin. I am so pleased today to introduce Jessica Zeman. She's a social worker or LCSW at the Mayo Clinic Health Systems in Wisconsin. She's been a social worker for a nephrology dialysis in a dialysis setting for over 17 years, and she is on our behavioral health depression advisory committee. And thank you so much, Jessica, for being here today.
Thank you very much, Renee. I appreciate that. You can go to the next slide. All right, I just made up a quick agenda, and we'll just go to the next slide. I know we're a little short on time. So I'm going to start with person A. This is a male, age 60, active person, enjoys his family and friends, works full-time in an office setting, has been there quite some time. He has been following with a nephrologist for 3 years and now has kidney function that is declining. So he is discussing options with his nephrologist. Next slide, please. So right away, I want to talk about health equity. The United States goal is to provide every person with the same opportunity to receive high quality health care, regardless of their income, their race, their age, and remove any obstacles in healthcare, such as poverty and discrimination, which can cause a lot of worry for some patients. Since the conditions of coverage set by Medicare, the outcomes across various geographic and health equity factors are basically the same across the whole industry as a whole. This is the result of having the same clinical expectations, employing the same kind of clinical protocols, providing clinicians with the same training, and allocating resources to improve the outcomes of lower performing centers. Next slide, please. So I really love this graphic here talking about equality, equity, and justice. Obviously, the end goal is to shoot for justice. We want to remove the causes of inequity and make sure that everybody has opportunity. The barrier has been removed. All right, next slide, please. The progress of ESKD care has advanced. The conditions of coverage have improved dialysis and treatment and transplant medical care. The barriers have been removed and kidney failure treatments are available for all people. But people are multidimensional in so many different ways. Medical care is only one aspect of their lives. Justice has not been achieved in other areas of our society with our patients. So let's take a look at social determinants of health. There are multidimensional aspects linked to poor health outcomes. Emotional or financial crisis, inadequate access to food, housing instability, financial problems, unreliable transportation, having one or more health condition, violence, limited or unreliable access to things like water, electricity, refrigeration, or plumbing, and poor income, educational, or employment opportunities. Next slide, please. So people, we are really here for people. We take care of people. Using health equity concept and social determinants of health allows for a clearer picture of who these people are. When they walk into our clinics and dialysis center, they become our patients. When they leave our clinics, they are whole, complete people with multi-layers of who they are and where they come from. Recognizing who our patients are as an individual person, as a people, is vital for quality patient care. Next slide, please. So let's take a look at mental health. The definition that I found, mental health includes our emotional, psychological, and social well-being. It affects how we think, how we feel, how we act, and helps determine how we handle stress, relate to others, and make choices. So factors that could potentially result in poor mental health, these are just the same exact key aspects that I just read you from the social determinants of health, and that were linked to poor health outcomes. So poor health outcomes, poor mental health, these are big, huge key aspects. Next slide, please. So one aspect of mental health is depression. There obviously are lots of other mental health issues. People who experience depression, they experience it in different ways. It can also influence the severity of some other chronic health conditions. I thought this was super interesting. Conditions that can get worse due to depression include diabetes, #1 risk for end-stage kidney disease, cardiovascular disease, and hypertension, #2, #3 risk, obesity, #5 risk for ESKD, and then arthritis, asthma, and cancer. Next slide, please. So let's take a look at our person A. He does have some concerns about how's he going to be able to get to work if he starts dialysis treatments. He's worried about his income and his rent and his food costs if he's not able to work due to having to start dialysis 3 times a week. He has an older working car and is worried about the cost of car repairs or his car breaking down. He loves his job. His job is a large part of his self-identity and who he is, but he worries about managing his workload and even potentially losing his job. He is tired, so tired all of the time. He knows he's forgetful, so he's been using a notebook to write things down. He has no motivation to make food for himself, and then when he actually does, he doesn't want to eat it, and it just doesn't look good. He just can't seem to make any decisions and gets easily agitated. What are we seeing here? Are these symptoms of depression or ESKD? Next slide, please. Let's take a look at some of these depressive symptoms that we know are true. Appetite or weight changes, eating or sleeping too much or too little, having low or no energy, difficulty concentrating, remembering, or making decisions, feeling unusually confused, forgetful, on edge, angry, upset, worried, or scared, feeling helpless, hopeless. The list goes on. Now let's take a look at the ESKD symptoms: poor appetite, insomnia, easily fatigued, change in mental alertness. And that list goes on. There is so much overlap here that it is very challenging to figure out what is what. Next slide, please. And then if you take a look at the social determinants of health that I discussed earlier, person A also expressed concern about emotional or financial crisis, financial problems or concerns, having one or more health conditions. So all 3 of these are huge concerns or key aspects to person A's life. Next slide, please. So what do we do? He presents with a multitude of issues across the spectrum of depression symptoms, social determinants of health, and ESKD. Is it as simple as telling the patient to get an appointment with a mental health provider, continue to jot down notes in his notebook when he forgets things, those symptoms are normal, and just start doing in-center dialysis treatments? No, it is not. There is so much more to the multidimensional layers of person A. So, a potential plan. We will communicate with a nephrologist about person A's care. We will assess person A using tools to help him get a picture of his quality of life and depressive symptoms that he may be feeling. The PHQ, KDQOL, GAD-7, etc. We will talk with the patient and discuss treatment options both for his ESKD and for his mental health, both equally as important. We will help him overcome barriers that are restricting him from doing the things he wants or needs to do. And who will be doing this? The entire team, each bringing different knowledge bases and perspectives. Next slide, please. There are many comorbidities and other factors that also may be causing some of the symptoms person A is feeling. Diabetes, medication interactions, changes in blood pressures, not being active enough during the day, thus difficulty sleeping at night, lack of routine, diet changes. The nephrologist should be consulted to account for physical medical complications. Perhaps by changing a medication, symptoms will be alleviated, or maybe that will make a difference for him. Next slide. As we know, there are many depression screening tools. I've just listed a few here. The Beck Depression Inventory, the Center for Studies Depression Scale, Hamilton Rating Scale, QIDS-SR, but the most popular that we tend to use is the PHQ. I believe Carri mentioned using the PHQ-2 and then moving on to the PHQ-9 if some of the scores are indicating depression symptoms. Next slide, please. So how do we do all of this? Patients receiving medical care state how they are sick of getting surveys. If I get one more survey, I am going to absolutely scream. I don't want to do a stupid survey. As social workers, we have the skills to balance patients' rights to say no versus careful assessment of depressive symptoms. What works for me is I ask the questions in a conversation instead of a formal survey format. Next slide. So now what? A patient scores high on the PHQ, indicating a high number of symptoms that could potentially indicate depression. Social workers rarely have the time or the privacy in the dialysis units to practice long-term counseling. Find out what treatment method would work best for the patient and help them work towards success. This may include a wide variety of treatment options for their mental health. Next slide. So treatment options, it could be psychotherapy, which is more like the talk therapy. You may have heard buzzwords like DBT or CBT. These are simply therapy options within psychotherapy. There are medications that are commonly prescribed. Not all nephrologists are willing to prescribe them. Sometimes patients need to go to their primary care provider to get an antidepressant, but that certainly is something that social workers can help the patient if they want to. And there's natural remedies and lifestyle tips. Exercise, avoid alcohol, drugs, set limits, eat healthy, get a good night's sleep, participate in enjoyable activities. Next slide, please. Going back to the social determinants of health, these are all very heavy challenges, but as social workers, we are trained to address these types of heavy challenges. We are the resource people to find more resources. We are the support people to help people find the resources they need to succeed. Next slide. So here are some natural remedies and lifestyle tips that social workers easily can provide to patients. Track gratitude on a journal. Do something you're good at to build your self-esteem and confidence. Try something new. Show some love to somebody in your life. Take time to laugh. Take 10 deep breaths slowly in and out. And smile. Sometimes just making yourself smile will make you feel better. These are all things that anybody can easily do to help support people feel better. Next slide, please. Oops. So looking at barriers, in order to determine barriers, you have to first look at a goal. So I just put a simple goal. I could very easily see a patient saying, well, I want to have more energy. I probably should exercise more. I probably should get some good sleep. So helping the patient break that down into the specifics of the goal. Okay, in order to get more energy, you're feeling like exercise. Okay, so let's set a goal. Exercise 3 times a week. Okay, let's get 8 hours of sleep. The barriers, they're going to put up barriers. We often do. We do it with ourselves. I don't have anyone to exercise with. I have a barking dog in the neighborhood that keeps me awake all night. They can go on and on. Social workers are great at helping patients find resources to help overcome barriers, large or small. Next slide, please. So some of the barriers that that people have to get, for some of the majority of people, the main barriers for mental health treatment are the financial barriers, the cost. Even if they have insurance, it can be too much. Lack of mental health care professionals. Nationally, we know there's a mental health provider shortage, and waiting lists are long. Limited availability about education and awareness simply about mental health. We have all heard about reducing our sugar consumption, for example, but how often do you hear about doing daily deep breathing? You know, as a society, we focus way more on our physical health than our mental health. Racial barriers to mental health care. Young men, Black adults, and uninsured people are the least likely to seek and receive mental health treatments. Next slide. Social stigma of mental health. A person's own belief about mental illness can prevent them from acknowledging their illness, seeking help, or sticking with treatment. People may fear that family and friends will avoid them or treat them differently, that disclosing a mental health condition will lead to adverse treatment. Even calling the symptoms depression can cause people to be fearful of social stigma. And then appointment burden. Patients who receive dialysis treatments and who have multiple comorbidities express simply having too many appointments and decline further options, even virtual options to get mental health care. Next slide. So what might a social worker and or the interdisciplinary team do to help person A? An assessment. Find out who he is, what is important to him, what his goals are, what is he most worried about, who is his supports. Assess for any suicidal, homicidal ideations and deal with them urgently. Set goals, determine what he feels he can accomplish and offer support. Provide education about his treatment options in a way that he can understand. Provide education about how his mental health and physical health are interconnected, and it's okay to talk about both. Complete a PHQ, complete a KDQOL. Offer assistance and resources to help address any social determinants of health concerns. We use multiple ways of communicating with him to assure the message is received. And I was thinking about, verbally and written and anything else that can be helpful for him to remember. What you see is not always what you get. The most important aspect of being a social worker is to ask the person about themselves, ask those tough questions, complete the PHQ in a conversation style and you will get more information than simply a rating on a scale. When you know the patient as a person in a multidimensional way, They will know you care. Their self-disclosure to you in conversation about their mental health will offer more than any survey would be able to provide. And that's all I have. Does anybody have any questions?
That was excellent, Jessica. I'm going to take just a moment. I think mostly kudos, requests for the slide deck, which we will put on the NCC website, and a copy of the presentation will also be on the YouTube NCC page. Just lots of kudos. Thank you so much to Carri, Nicole, Jessica today. I'm going to run through a few more slides. If you do have questions for any of the presenters, now's a great time to pop them in the chat section. I'll go through some final housekeeping and we'll close for the day. So, now that you've heard these presentations, and I will link to the change package, how likely are you that you would use something from the change packages or that you heard today back at your organization? Again, we're really trying to move these from learning to action within our national networks. So in that spirit here, if you see there's the QR code, you can use your phone's camera option right now to be directed to the change package on our site, or the link is there. Great, seeing some folks is not currently offering CEUs for these, although we have thought about that. Again, lots of kudos for the presenters. Thank you. Thank you. I think it's the strategy and tactics, but too some of just the energy and enthusiasm that we probably could all use some days. So appreciate that. I don't see any other questions coming through. You can always follow the ESRD NCC across our social media. And there will be a survey once you close this browser, then it will take you directly to a Survey Monkey link. If you could take that and just take a minute, fill that out for us. It helps us as we run these learning action networks across a variety of topics. So if you found this one helpful, share with your colleagues. We also do them on home dialysis, transplant, vaccination, and dialysis care in nursing homes. Yes, I'm going to go back to the QR code for one request there. I'll leave it on this page. So the QR code will take you directly to the depression change package, and that is culled from top performing facilities across the country for their best practices, really easy, primary and secondary drivers, action tips, along with everything we heard today from Carri, Nicole, and Jessica. Again, thank you, everyone. Thank you to the community. Thank you for all the wonderful work that you do. Thank you to our presenters and our networks today. Please, be on the lookout for other ESRD NCC resources and take good care.